Good evening and welcome to one and all. I am Rituparna from Planet, the designated session assistant for a seamless experience. And Planet is India's most trusted and widely used digital platform with multiple enriching services exclusively for the doctors. Planet is very proud to be digital partner for this event called E-Gurukul Pathshala, and the topic for today is case discussion on neonatology, organized by the Indian Academy of Pediatrics, Gujarat. So without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Neha Patel, the professor and HOD, GMFRS, SOLA, and also one of the noted project coordinators of this program. Over to you, ma'am. Please proceed. Ma'am, sorry to interrupt, ma'am. You are muted. Kindly unmute yourself.
Okay. So I once again welcome you all for our program E-Gurukul Pathshala PG Clinic every Saturday 6 to 8 p.m. Today there is a case on discussion on the neonatology. I welcome our project in charge, Dr. Yogesh Parikh sir. Sir, please.
Yeah. Good evening all and warm welcome to the E-Gurukul Pathshala. Today's session with the neonatal case presentation from the GMRS Medical College, Sola, Ahmedabad. And we welcome Dr. Dhaval Delvadia as a presenter and Dr. Dipti Shah, the Associate Professor of Pediatric, Department of Pediatric, GMRS Sola, Ahmedabad, as a mentor. And we have two experts, legends in the neonatology field of the neonatology, Dr. L.S. Deshmukh sir from the Aurangabad, and Dr. Kunal Ayya, our own youngster, young buddy neonatologist from the Rajkot. So we welcome Dr. Dipti and please introduce our both the expert faculty. And we are waiting our moderator and the project convener, Dr. Baldev Prajapati sir. He will join the soon. Over to Dr. Dipti.
Good evening, all of you. I'll welcome our experts, Dr. L.S. Deshmukh sir. He is professor and head of Department of Neonatology at Government Medical College, Aurangabad. He is past president of MSNNF. He did his MD Pediatrics, DNB and DM Neonatology. He is Commonwealth Fellow. He is Fellow of International Society of Quality in Healthcare. He is member of editorial board, Indian Journal of Maternal, Fetal and Neonatal Journal from Red Flower Publications. He is reviewer of many journals like BMJ Quality Journal, PLOS1, Journal of Neonatology, Indian Journal of Child Health, and Indian Journal of Case Reports. He is member of Board of Studies of MUHS Nasik and Pravarna Institute of Medical Science, Deemed University, Loni. He has done many publications in international and national journals. He has written 7 chapters in books, and area of interest is quality improvement in neonatal infections. I welcome you, sir. And our next expert is Dr. Kunal Ayya. He is director and consultant neonatologist of Mahi Newborn Care Center, Rajkot. He was university first in MD Pediatrics. He did his fellowship in neonatology from Bharatiya Vidyapit, Pune. Special area of interest are point of care neonatal ultrasound and neonatal nutrition. He was editor of NNF Gujarat 2020-22. He was secretary of Academy of Pediatrics 2018 and 19 at Rajkot. He was executive committee member of NNF Gujarat, AOP and IMA Rajkot. He is national faculty for point of care neonatal ultrasound, and he has published many international and many articles in international and national journals. He has done many paper presentation. He is author of various chapters in various books, and he is editor of 2 books. Welcome you, sir.
Thank you so much.
And we have our own 3 national coordinators of this project, E-Gurukul Pathshala, Dr. Nehal Patel Madam from the Ahmedabad, and Dr. Aarti Kinikar Madam from the BGMC Pune, and Dr. Vaishali Joshi Madam from the Government Medical College, Goa. So we are going live now. So, Madam, we can start now. Prajapati sir will join.
Prajapati sir has texted that he will join short. So we can start with the case. Our two experts are there who can continue the case discussion.
Okay, go ahead, please.
Can I start, sir?
Yeah.
Uh, hello. Am I audible?
Yes, Dhaval, continue. Yes, you're audible and continue. All the
Good
best.
evening, everyone. Myself, Dr. Dhaval Delwadia, from GMRS Medical College and Hospital, Sola, Ahmedabad. I am presenting a newborn case under the guidance of Dr. Dipti ma'am. Baby of XYZ, male child, now 45 days old, informant being mother with good reliability, born of non-consanguineous marriage. Mother was 27-year-old with third gravida with two live children. Mother gave birth to the male child via normal vaginal delivery at 31 weeks plus 5 days of gestation with birth weight of 1.3 kilograms. LMP was 27/8/2022 and expected date of delivery was 3/6/23. Mother blood group and baby blood group both were O positive. Baby was admitted to the NICU in view of respiratory distress, preterm care, and rashes all over the body. Antenatal history. Mother age is 27. Pregnancy was registered. Total antenatal visits were taken 6. Weight gain during the pregnancy was 6 kg. Pre-pregnancy weight was 36 kg and at time of delivery, mother's weight was 42 kg. First trimester, it was spontaneous conception confirmed by the urinary pregnancy test. First antenatal scan was done during the first trimester at around 12 weeks, which was normal. No any history of excessive vomiting, fever with rash, any exposure to drug or radiation during the pregnancy. HIV, HbSAg, VDRL were negative. Folic acid taken during the first trimester. Blood pressure was normal. During second trimester.
One moment, Dhaval.
Yes, sir.
You mentioned that the baby was delivered preterm, whatever
Yes,
it is,
sir.
31 plus 5 days. Any
31.
probable reason for premature delivery? Did you
No,
inquire
sir.
into that?
No particular
Was it
reason.
a spontaneous
Yes,
preterm delivery or it was an
yes.
induced?
No, it was a spontaneous normal vaginal delivery.
Okay. So what is the significance of that? It was spontaneous versus induced pregnancy.
In induced pregnancy, there are the chances of
Okay.
birth,
Yes.
birth trauma, birth asphyxia, like.
Now, why do you think so? Induced preterm delivery is at risk of excessive injuries to the babies.
Because
induction will be mainly for the most of the times it is maternal indication, isn't it? Most commonly we see
mostly due to
PIH.
maternal indication. Yes,
Yeah,
yes.
most commonly we see PIH or maybe mother is bleeding, antepartum
Yes, sir.
hemorrhage or intrapartum hemorrhage. But in this case, it was a spontaneous delivery. So what is the most common cause of spontaneous delivery and what is our concern when the baby is admitted to NICU?
It might be due to any intrauterine infection or something.
Like
DORG infection, congenital TB. In such cases.
No, don't just jump to that. It is an indicative of spontaneous preterm labor. It is indicative of risk of infection. Most commonly, it can be micro leaks in the amniotic sac, or it could be infection, chorioamnionitis, sometimes cramp.
Yes, sir.
So we are worried about that. In early onset sepsis, that is one of the risk factors.
There is no history of PPROM in this case.
Yeah. Okay. And secondly, you mentioned no history of. Can you go to the first slide?
Yes, sir.
So baby was presented to NICU with respiratory distress, preterm rashes all over the body. So what is your first impression?
So
This
first
baby
impression was
comes at birth with this manifestation.
I was suspecting preterm low birth weight with any congenital infection, which is presented as a races all over the body.
What about respiratory distress?
It's a part of prematurity, which is presented as it might be RDS due to HMD, due to
Okay,
immaturity
yes.
of lungs.
Yes, it
Yes.
can be RDS. What else it can be in the given scenario? The rash
So
is so less likely.
races were, sir, typically petechial races, non-branching in nature, which is spread
Respiratory
all over the
distress,
body.
in such a scenario, we always keep a possibility of congenital pneumonia. In all
Yes.
babies who are preterm with respiratory distress, one of the differentials apart from RDS remains congenital pneumonia.
Pneumonia, yes, sir.
Yeah. Yes. Go to the next slide. Now that is okay. What to make out of this antenatal history? Any significant thing which comes to or which looks into your
No, sir.
face?
Actually 6 kg weight, but for
Yeah.
premature delivery, I think it's okay for this baby.
32 weeks, at 32 weeks, 6 kilos.
Little bit
What is the
less, but
average
yes,
weight gain? What is the average weight gain in
average weight.
Indian scenarios?
It's around 6 to 10 kg, sir, for Indian scenarios.
Maybe a little higher also, up to 12 kilos, 8 to 12 kilos also. That we
Okay,
speak of a term mother, isn't it? But this
yes,
is a preterm 32 because
preterm,
so
sir.
okay, kilos, but still it appears on lowish side.
Yes,
That's
sir.
fine. Next slide. And here you mentioned about no history of excessive vomiting. Anything
Yes,
in your mind when you say that?
Hyperemesis gravidarum can induce sometimes spontaneous labor, and baby might deliver
Now,
prematurely.
this is 32-weeker, isn't it? So
Yes, sir.
hyperemesis, is it a persistent phenomenon? Does it last throughout the second
No,
as
it
well as the
doesn't
third
last for
trimester?
third. No, sir.
Mother is already into third trimester.
Yes, sir.
So it's less likely, isn't it?
Yes. Right.
Yeah. And you mentioned about any exposure to drug or radiation. Do you have anything in mind when you ask that? Any drugs you have in mind, any particular drugs? Or it is just as a part of, routine?
Sir, I asked about drugs as there was a rashes since the birth. So if mother was on any hemocoagulant drugs matlab, aspirin, warfarines, and it might be presented as matlab, bleeding tendencies are there in babies also. That's why
Okay.
I asked about the drugs, and
Okay.
radiation I asked as a routine, and I asked about the fever with rash
But
because
how does the radiation affect the baby? And which exposure we are concerned with? I'm just asking Neil madam, with your permission, because you've thrown this responsibility on me. Kunal is there, but so you
Yes.
should take over. Because I told madam that I am not used to taking the exams of MD pediatrics. But excuse me if I am deviating.
No, sir,
No,
no.
sir, definitely. You are going well, very well, and so please
Yeah, but
continue.
that was not the initial plan. Anyways, so
So we are
radiation.
fortunate to have you.
No. It's my pleasure, ma'am. Yes, radiation, are you sure? Just one thing for the postgraduates, you should, whenever you mention anything, it should be always correlative in the histories. Just don't, like an undergraduate, I understand that they put in everything inside, lot of things they ask, which is not expected of postgraduates. Postgraduates have to keep tab on what type of baby I'm dealing with and what I'm looking for in the maternal history, the antenatal history, the preconception, everything. And some of the things are there which are asked for all pregnancies, irrespective of how the baby is presenting. like the supplementations, antenatal scans, registered or unregistered or booked or whatever. Isn't it?
Yes, sir.
Yeah, go ahead.
In second trimester, quickening was felt at around 4 months. 2 doses of TD were taken, 1 month interval. Iron and calcium supplements were taken regularly. No any history of UTI, fever, headache, bleeding for vagina or leaking for vagina, or burning micturition during the pregnancy. Anomaly scan was done, which was normal. No any documentation or mother was not remembering the exit dates. BP measured and found to be the norm.
1 minute, Dhaval. I welcome Dr. Baldev Prajapati, sir. Sir is
Yeah,
now
good. Sir
here
has
to
come.
guide
Good.
us.
I am relieved.
No, no, sir, you have not read.
You are not relieved. So, Baldev sir, do you want him to go for 2 slides earlier?
Sir, you are mute, sir.
Am I audible?
Dhaval?
Yes, sir.
Yes, sir.
Good evening, sir.
Good evening, good evening. I'm not able to join with my laptop, so
Oh,
I'll
anyway,
just
sir,
try
but
with
we
this.
are waiting eagerly for you. So
Thank you.
good that you have joined. I am
Thank
relieved
you.
of some burden.
No. Thank you very much. I tried with my iPhone, so I will continue. Please
Yes.
go ahead. Go ahead.
So you can take over, sir. We are just starting with the history. He
Please,
is into
please,
first trimester only.
please, you continue. Once my laptop is working, I will again join. But please
Yes,
go
sir.
ahead.
No issue, yes. Neil, madam, you mentioned about one thing in the question. Does it look like more of congenital pneumonia with rash? It can be, because bacterial pneumonias can have very rapidly, they can develop, deteriorate in our circumstances particularly. We have seen babies within 6 to 8 hours, 12 hours developing petechiae and rashes and bleeding and frank sepsis. So yes, very much it is likely that this could be congenital pneumonia. But in our, what my observation is, I am in the public hospital. So every time there is an RDS baby, unless the mother has received complete steroid course and mother is otherwise followed very closely, monitored, we used to always keep the possibility of congenital pneumonia in our circumstances. Yeah. Just go ahead, Dhaval.
Third trimester, total weight gain was 6 kg. Normal perception of fetal movements are there. No any history of antenatal steroids were given or magnesium sulfate. No history of epigastric pain, burning vision, pedal edema, easy fatiguability, and breathlessness. BP was measured and found to be normal.
What is the course of antenatal steroids? What is the dose recommendation?
In Indian scenario, we generally give injection dexamethasone, 6 milligrams every 12 hourly for total 4 dose, total 24 mg. And betamethasone, we are giving 12 mg.
Which babies we give steroids?
Less than 32 weeks.
32 or what is the recommendation? WHO recommendation? Is it 32 or 34? It is less than 34 weeks, isn't it? Usually WHO comes out with this kind of recommendations. Any mother who is likely to deliver preterm less than 34 weeks, we start antenatal steroids, isn't it?
Yes.
Kunal sir, you can just, if I am wrong.
No, sir, you are perfectly correct. So there is so many risk factors are there in this case. So one is the baby is born preterm. Second is the antenatal steroids are not given. Mother is also an underweight mother is there.
Yeah.
So multiple risk factors are there for this case.
Correct. Yeah.
So we will have to keep those points in mind, and then we can proceed with the case for further this thing.
Yes. All right.
Can I go further, sir?
Yes.
Okay. birth history. It was normal vaginal delivery was done on 17th April 2023 at 9:21 p.m. With a gestational age of 31 weeks 5 days. Male baby with birth weight of 1.3 kilogram was delivered. Baby cried immediately after birth. Apgar was at 1 minute was 7 and 5 minutes was 8. Injection vitamin K was given. Baby was shifted to NICU in view of respiratory distress with preterm care with the petechia all over the body. After admission,
Dhaval, what was the management done at the time of birth in this baby?
Yes.
So this was
Uh,
baby was having respiratory distress. So what was the saturation of the baby? How did you manage the respiratory distress in this case?
sir, child was put on TPC resuscitation and shifted to the NICU initially after delivering in labor room. After shifting in NICU, there is SS score was around 7, and restrictions were there. So we advise for one chest X-ray, which is suggestive of picture of HMD. Then we intubated this child in view of respiratory
That
distress
is, you
with
are telling me, I am
severe.
asking you about the birth management of this baby. You are telling me the NICU management. I want to know about the birth management.
Yeah.
So you said the baby had cried immediately after birth. Then
Yes,
the
cried
baby
immediately
was
after
developed
birth as
respiratory
child was
distress.
preterm.
So yeah, the baby was preterm. So what all care had you taken for this baby at the time of
Cling
birth
wrap,
as well as during transportation?
cling wrap was applied at labor room, and
Okay.
child was put on TPC resuscitation for
Had you taken the
there was
saturations of the baby at the time of birth? Whether do you have any air oxygen blender at your unit, or you just give 100% oxygen with TPs?
Sir, in labor room actually we don't have a blender, but we
Okay.
generally give 100% of oxygen. Ideally, it should be given with blender to
Okay.
titrate the oxygen saturation.
Okay. Delayed cord clamping.
In this case, it was not done, but ideally it should be delayed as the child was preterm around 1 minute, so that around 70% of blood will be transferred from the placenta to the baby, around 20 to 30 ml per kg.
Not 20 to 30 ml would be a large number for this baby. But yeah, there is the placental transfusion is there. One thing is you have to maintain the temperature. What you told is that you had given a clean wrap.
Clean
Very
wrap.
good thing.
Yes.
TPs resuscitation is an ideal scenario. Delayed cord clamping should be practiced in those. We always mention it that you have pre-warmed the room and that adequate temperature control was taken care of, because some babies might have distress just because of hypothermia. So in this case, what is your NICU admission? That also matters, because some hypothermic babies can present with respiratory distress.
Okay, sir.
So, Kunal, other students are there, Dr. Chinmay, Dr. Aarti, Dr. Nihal. So you can include them also during the discussion.
Okay, sir.
Yeah, okay, thank you.
After admission to the NICU, baby was kept on conventional ventilator in pressure SIMV mode. In view of respiratory distress with SS score was 7, and chest X-ray was suggestive of RDS stage 3. UDC was secured after the admission. Surfactant Curosur 2 ml per kg was given with a quick push method and kept on the conventional ventilator mode. After surfactant, pressure support was decreased. PEEP was decreased to 4 from the 5, and pre-inspiratory pressure was decreased to 12 to 10. CBC was sent in view of generalized petechia since birth as there. So CBC suggestive of HB 16.8, total count were 9,300 and platelet count was 1.3 lakhs. Dose profile of baby and mother sent in view of petechia since birth. Minimum enteral nutrition RTF was started.
Was the one moment, Dhaval, was the initial management You think the respiratory management. That is the recommendation. You kept the baby on conventional ventilator, SIMV.
Yes, sir. Child is having severe retraction and respiratory distress with SS score was 7, and X-ray chest was suggestive of HMD. So we put this child on.
Initially, you just manage the baby. X-ray is not going to alter many things. You have to realize all of it. X-ray, whether it shows something or not, irrespective of that, the baby has retractions, baby has severe SS score which is high, or sorry, whatever score it is there. Then you will have to initial management protocol remains the same. It is invasive to non-invasive.
Initially,
Or
child was
non-invasive to invasive. What is it?
non-invasive first.
So the
If
non-invasive
child is
first
manageable or
you
non-invasive.
initially will manage with maybe CPAP. If your unit has
CPAP, yes.
policy of NIV, you will give NIV. And if that, and simultaneously if he is not improving, then what is next thing? Will you intubate?
We increase the pressure requirement in non-invasive.
Okay, that you have reached. FiO2 is going already over 60%, so it is a
Yes.
surfactant. You are already given that surfactant. So NIV, CPAP, CPAP oblique NIV initially, then immediate surfactant within 2 hours. And then if the baby doesn't respond, you go for intubation.
Intubation. Okay, sir.
Dhaval, what is the FiO2 cutoff limit for giving surfactant?
40%, sir.
Yes, so 40% that on optimal pressures. What you have given is, first of all, what the baby should have been managed, it should be kept on SRS told, should be kept on CPAP itself.
CPAP, yes.
Even if there are distresses there, then you can give a higher PWP. So even if you have given 5, you can give 6 also. Second thing is, if the baby is not maintaining on that, then plan of if the FiO2 is more than some units say 40, some units say 30%. So if you're irrespective of the X-ray, if your FiO2 requirement is above 30%, then you give surfactant, give it by Ensure method or Lisa or MIST method. That is least invasive surfactant administration. Or if you are not well versed with it, then at least you can give it by an Ensure method. And you again put the baby on CPAP and try to avoid intubation as far as possible. Even a single intubation, even a single puff of bag and mask ventilation, bag and tube ventilation can increase the incidence of CLD. So you should not. Second thing is your ventilatory management proper? Your pressures and FiO2, do they correlate? A 12 of PIP and 80% of FiO2 doesn't correlate. Okay, so if your FiO2 requirement is high, that means that your PIP requirement should be high. So what you are giving is a mismatch of ventilation. So ideally your PIP, your PWP should have been given initially higher, and on that setting you should have assessed the FiO2 of the baby.
Yeah.
You cannot assess the FiO2 on 12 PIP. That is almost an extubation setting. At the extubation setting, you are giving a deciding your surfactant strategy. So your PIP, if actually this would have been required, would have been anywhere between 18, 20 or even higher also. And if you had given a proper PIP, the retraction should have come down and your FiO2 should have come down. And on that FiO2, then you will have to decide whether you want to give your surfactant or not. Second thing, second thing is, why had you decreased your PWP in this patient?
Yes, after giving surfactant, yes.
So you should have kept your PWP slightly higher.
Okay.
Okay, fine. Yeah, proceed, please.
Continue with 5, I think.
Yes.
Okay, sir.
One moment, I just want to add here is, you have to know that the concept of ventilating, whether you ventilate with non-invasive or invasive approach, is open lung ventilation or open lung strategy. Because unless and until the lungs are open, even the surfactant is not going to be effective. So you have to don't have the pipophobia, PWP phobia, Hypophobia is the biggest cause of not recruiting the lungs, and baby is not improving, particularly if the baby is on non-invasive. I mean, you can go up to 7, 8 of CPAP, or in NIV also you can go for higher pressures. Try to open up the lungs and then only give surfactant, and that is another approach which is called as inrexure. Intubation, recruitment, surfactant, and extubation. That is another approach. But the bottom line here remains is you are try to open up the lungs, and unless and until the lungs are open lung strategy, you are likely to, baby is likely to deteriorate and not respond even to surfactant. Because it will, surfactant will be unevenly distributed.
Okay, sir.
Yeah. Go
Sir,
ahead.
one question. As child is preterm and having weight of around 1.3 kg, up to how much PIP we can deliver to in such scenarios, or PIP?
PIP, as sir has told you, you can go up to 20 also.
Okay, sir.
I mean, in your case, it is a pressure mode you are mentioning, I guess, the PSI means. It is not
Yes,
volume guarantee, isn't it? VG mode. It is not VG mode.
No, it's not volume control, it's a pressure control assignment.
Which ventilator are you ventilating this baby on?
Sir, we are having Allied ventilator.
What is that?
Allied, company name is Allied.
Oh, I have never used that company. I used others. I use KBN, I use Zacotronics, I use Schiller, I use Draeger, I use even Bella Vista, but not sure. Even the Mackey we are using. But you see the initial, now the strategy is changing all over. There is another thing you have to remember, that when it is an ventilation, it is volume guarantee only. So volume targeted, volume guarantee, that kind of ventilation is more and more being used. People are moved away from the pressure control kind of a thing. So in those scenarios, you don't have to control PIP, you just control the PEEP and expiratory pressure, which can be, you should have started with 5 at least, if not 6. 5, 6 is good enough. But as sir has mentioned, Kunal sir, you could have gone higher up on the PIP. Yeah.
Yeah, thank you, sir. At the 20 hours of life, inodrops injection dobutamine at the rate of 10 microgram per kg per minute was started in view of shock with febrile pulses, and CRT was more than 3 with tachycardia was there. ABG was performed and suggestive of metabolic acidosis with pH was 7.19, PCO2 46, PO2 144, lactate was 2.2, bicarb was 18.3, base excess was minus 8.2, and SO2 was 100. Septic screen was
One moment, Dhaval.
Okay, sir.
What is your comment on the ABG? Is it a metabolic acidosis? Apparently, it doesn't look to me as a metabolic acidosis straight away. With excess of -8, okay, little highish, lactate appears okay. PO2 is high, PCO2 is highish only. I mean, it is hovering around normal, but it is highish. So PCO2 as well as your this thing. So is it a mixed acidosis, or is it just purely metabolic acidosis? And if it is metabolic acidosis, I mean the lactate is normal. What is your comment on that?
So it's a mixed type of
It could be, it's very difficult to comment, but it looks like it is not just, I mean, not convincing that it is just metabolic acidosis. Yeah, go ahead.
Septic screen was sent, which is with CBC. HB was 17.6. Total count decreased to 7,700, and platelet again decreased to 65,000. And CRP was borderline 0.6. First line antibiotic was started. Injection cefotaxime.
One moment. What is the sepsis screen? What do you mean by sepsis screen? What are the components of sepsis screen?
We send sir CBC, CRP, and blood CS. As blood CS
That is
takes
okay,
time.
that you are saying, but what is sepsis screen? What do you mean by sepsis screen? Is it just CBC and a CRP, or there are not? What components of CBC you look at closely? When you say sepsis screen,
We look for the HB, hematocrit, total
hemoglobin
count.
is part of sepsis screen. It's not part of sepsis screen.
We look for the total count and platelet counts.
Just two things. So what is the total count here is 7,700. What is your comment on that? Is it normal or it is high, decrease? What is it? When do you say leukopenia?
It's a normal for this child. As the previous one was around 9,800. And the platelet count was decreased. So we consider this as a shock and decrease in platelet count, considering as
Cutoff. What is the cutoff? I'm not speaking about using a dedicated charts. There are charts also for leukocytes, for platelets, for hemoglobin. But irrespective of that, for clinical practice, day-to-day practice, less than 5,000 total count is taken as leukopenia, isn't it?
yes, sir.
So other PGs also can comment on that if they want. And what about the ANC? Absolute neutrophil count. Is it part of sepsis? It is also part
Yes,
of
sir. It's part of sepsis. Yes, sir.
is total leukocyte count, ANC, IT ratio, and micro ESR. We used to do that initially. But now the micro ESR is no longer being done by laboratories also, as well as the side labs also are not doing that. So gradually, unknowingly, the other components have crept in. Other components are platelet thrombocytopenia is one component, and the CRP is another component. So the old sepsis screen was just these four things: total leukocyte count, ANC, immature
ratio.
ratio,
Yes.
and micro ESR.
Yes, sir.
Now the platelet count also we look at, and the CRP levels. But CRP you mentioned here as a 0.6.
Yes, sir.
Is it borderline for your lab? I don't know.
It's starting from 0.6. So it's a positive, lab given as a positive, but it's starting from 0.6 only. So it's a positive.
I don't know.
Minimally
Kunal sir can comment on that. I don't know. In our side, it is different.
There are various units are there. Some
Yeah.
labs are showing it in 0.5, 0.6, or even in old unit like 5, 6 also. So I think in his reference range would be from, if he's saying that it would be from 0.6. Yes.
Yes.
Yeah.
But
Nehal madam, you want to comment on something about sepsis? You can come in.
Sir, I wanted your expert opinion about the two new things which are coming as a septic screen. One is procalcitonin and another is leukocyte platelet ratio. So any experience of the experts on this?
No, we have not used procalcitonin, though during COVID times it was very freely available and freely used. It is a non-specific, again a non-specific marker. All these inflammatory markers are non-specific only. But the procalcitonin has one problem which is very evident, is procalcitonin has a very short half-life. It rapidly rises and rapidly decreases. Unless you catch that peak, you are likely to miss the bacterial infection. But if it is raised, then highly likely that this could be bacterial infection. That is what is about procalcitonin. This ratio has recently been, there are few studies of this procalcitonin leukocyte ratio, but there is not a very convincing. My take for sepsis screen, ma'am, is immature to total neutrophil ratio is more, predictive of sepsis rather than anything else.
So,
Which is unfortunately not being used because it requires peripheral smear. The pathologists have to look at the peripheral smear, count the immature cells. So other things will be there once you do the peripheral smear, as you are mentioning, like toxic granules and other things.
so no single parameter is indicative of
Yeah,
sepsis in a preterm
exactly,
baby.
exactly.
So it has to be a combination of
That is
multiple
why it is a sepsis screen.
screen. Yes.
Unfortunately, I have observed over last 10 years or so, the CRP has taken over as a sepsis marker. So we now have an epidemic of CRP positive sepsis, where the babies are fine clinically. It is a clinical as well as the laboratory plus the collective, as you have mentioned, not a single parameter, but looking at all other parameters. Yeah.
So
Can I go ahead, sir?
Yes.
First line antibiotic, Taxim and Micacin were started in view of shock and thrombocytopenia. At 24 hours of life, screening to deco was done, which is around to be normal. At 48 hours of life, phototherapy was started in view of icterus. Ventilatory settings are gradually tapered, and by 72 hours of life, at 72 hours of life, we sent again the septic screen, which was positive. CRP increased to 0.6 to 5.6, HB decreased to 14.8, total count decreased to 5,900, and platelet again decreased to 55,000. There is a brownish RT aspiration was present, scleroderma over the face. So antibiotics were upgraded to second line antibiotics, injection piperacillin, tazobactam plus injection levofloxacin, and MEN RT was going on, which was stopped. On fourth day of life, UVC was removed and PICC line was inserted for the injectables. Blood culture at fourth day of life, blood culture was negative, which was sent earlier. At the fifth day of life, baby was extubated and kept on the bubble CPAP with a PEEP of 5 and FiO2 requirement was 30%.
One moment, Dhaval. You mentioned about levofloxacin. What is the dose of levofloxacin which was used?
10 mg per kg per dose, 40, single dose.
Okay. What is your experience? This is aside from whatever your case is, it is a question to Kunal or others of using levofloxacin. We are using ciprofloxacin.
we are using it. It has shown good results in our unit as such.
Okay.
Yes.
Yeah.
Dhaval, one thing is, why is the HB falling and what have you investigated for the falling HB?
14.8, yes.
17.7 was, if I'm not mistaken, was the previous
Yes,
HB.
initially it was around 16,
gram.
17 and now
Yes.
it's decreased to 14.8, yes.
Yes.
As sir, there were petages all over the body, so we were suspecting IVH, but there is no any signs of IVH there as such. Activity-wise, child was okay. Neurologically, there is no any signs. We suspected any internal bleeding might be there, but we sent this child for the after extubation. We sent this child for the USG to look for any other thing. But as a brownish aspiration was there, so we only suspected it might be internal bleeding, and that's why this HB was dropped.
So if echo was done, it's along with that you could have done USG brain also with the same machine.
At that time, sir, after at 72 hours, signs of IVH was not there, but
IVH might not always present with signs. There are various types of IVH also. Can be catastrophic, will present with sign, but subtle IVH will not present with signs. Just fall in HB activity, all those would be your fall in HB would be your initials. So any baby would, your baby had deteriorated at 20th hour of life. So there are multiple differentials are there, but some of them have to be different, have to be investigated earlier also. So can be PDA, can be IVH, can be sepsis, can be some internal bleeding, can be worsening of sudden worsening of sepsis also. So were the PTH increasing or were they same?
Packages were same, sir. They were
It
not
was not
increasing.
because of or your fall in HB.
Yes, sir.
Okay.
Uh, During that period, we received the.
One moment, Dhaval, you mentioned
Yes,
USC
sir.
was removed and PIC line was put. What is the reason, any specific reason for that?
Sir, there was a
On fourth
brownish
unit.
RT aspiration was there and AG was increased. So we prophylactically removed the UVC and started from the
Okay.
PIC line.
Okay, yeah. But I think that is not indicated, but anyways, that is a different discussion. Okay. But how long you can keep an EVC line in situ? Or you, I
We can
mean,
keep for 7 days.
pardon?
7 days, sir.
Okay. Average 7 days, you can keep it for longer period of time, depends on the context in which you are working. Are you in an overcrowded place where the asepsis is not very, I mean, it is suboptimal, then it is better to remove it early. Okay.
One more thing is you shouldn't avoid putting an PICC line during an episode of active infection. As well as you
Yeah.
had mentioned that you had put an PICC for administration of antibiotics. Ideally, you should not open the PICC line. It has to be reserved for your TPN or your fluids.
Yeah.
Only. So multiple
Exactly.
handling of this PIC line can also worsen your, increase your sepsis chances.
Yeah.
During this time, we received a torch profile of baby, which is a suggestive of CMV, IgM antibody positive
What
and
were
IgG
the
also positive.
markers of torch? One moment, Dhaval. In this baby, what were the markers of torch infection, which
In
prompted you
this
to send
particular baby,
the
sir,
torch, which was on day 2?
child delivered prematurely. It's one thing, and having patches all over the body since the birth. So these two are markers suggestive of there might be some congenital infection.
I don't think
Which
that puts you your torch higher up on the list. There are other pointers which are more important. Of course, thrombocytopenia is one thing. They take you okay. But then you have hepatosplenomegaly, IUGR,
there was no hepatosplenomegaly.
microcephaly.
No, had
Those kind of manifestations will prompt you to immediately send a torch, isn't it?
Yes, sir.
Premature, usually CMV babies are IUGR. So
Yeah.
it is not like you that was only PTH was there, but again.
Your baby
other
was
indications.
IUGR, AGA or SGA? What was it?
Child was AGA, sir.
Which have you plotted that on your chart somewhere?
Yes, sir. It's later on. It's
Okay. Don't go ahead. Just continue. When we
Okay.
reach there, we
Okay,
will
sir.
discuss. Yeah.
Okay. On day of life sick, CRP increased further. So antibiotics were upgraded to third line injection,
Go to the
meropenem and
report.
colistin.
No, go to the report.
Okay, sir.
What is your interpretation of this? IgM negative, IgG toxo negative, so toxo is out, Vela is
As IgM and IgG
out.
both are positive, so IgG generally is a transfer from the mother. So that's why child is showing IgG positive and IgM is suggestive of active infection.
Okay. What about AVDT? High AVDT. What does it indicate?
Titer of antibodies, sir.
High AVDT. CMG, IgG, AVDT. What is the utility of that? Low versus high. High AVDT means it is a little older infection. maybe there is a reactivation of infection in presence of IgM positive. A low AVDT means it is a recent infection. Usually this AVDT, you see it increases after say 3 months of persistence of infection. Yeah.
Okay, sir. On day of life 6, CRP increased further, so antibiotics were upgraded to third line antibiotic injection, meropenem and colistin. On day of life 7th, brownish RT aspiration was stopped. So RT feeding again started with 20 ml per kg per day. During the 8th to 10th day, patient shifted to CPAP to HFNC, and then on nasal prongs, RT feed gradually increased to the full feed, and supplements were added. KMC initiated and NNS also initiated. During 11th and 12th day, O42 trial was given, and child was shifted to the step down. On 13 to 20 days, towards profile of mother and baby were positive. Mother report suggestive of CMV, IgG only positive with high avidity, and baby IgM plus IgG positive with high avidity for IgG. Total antibiotics were given for 14 days. Then we sent urinary CMV PCR for this child, which turned out to be positive with viral copies of around 1.5 crores. USG skull CT had turned out to be normal. Eye examination, on eye examination, fundus examination, immature retina.
One moment. Dhaval, did you do a CSF of this baby?
No, sir, we didn't send the CSF for this.
Was it indicated in light of sepsis? I mean, the other question, direct question is, what are the indications for CSF in sepsis?
In late onset septicemia, we generally send CSF, sir.
Yes.
As this child is falling early onset septicemia, so we didn't.
Which early onset sepsis you should send CSF?
If blood culture was positive for gram-negative bacteria, then we have to send blood culture.
Oh,
sorry, CSF.
in this case it was negative, isn't it?
Blood culture was negative, sir. We sent twice, but
other thing is, though it is taught commonly that if the culture is negative, don't send it. Other thing, in our circumstances, my observation of our unit does practice doing CSF even in early onset sepsis. If number one, baby has CNS symptoms, that means not lethargy or poor feeding, it is seizures. And secondly, the baby has the scleroderma or severe kind of a sepsis. We always tend to do CSF rather than not doing it. And in babies with a severe sepsis, we do not restrict up to 14 days. We try to give for 3 weeks. Antibiotics,
So even in babies with early onset sepsis, you do get meningitis.
Yeah.
So if the baby is having such severe sepsis, then you should have done a CSF.
Just go ahead.
Eye examination, there is no any signs of retinosis, and immature retina is there in zone. ENT reference OAE bilaterally passed, which was followed up after 3 months. Routine investigation sent before starting the further treatment, which is suggestive of HB 12.8, total count 11,300, and platelet increased to 1.15. LFT SGPT slightly higher 71, and RFT was normal.
What are the USG abnormalities you expect if you are suspecting a torch, as you are, and already the CMV has turned out to be positive?
In USG, sir, there might be hepatosplenomegaly generally, which torch infection is correlated with hepatosplenomegaly generally is there.
USG skull, USG skull. What do you expect in a torch?
Periventricular leukomalacia calcification might be there in
Periventricular calcification, yes. What else?
Dilated ventricles might be there.
Okay, ventriculomegaly. Anything else? Other postgraduates can also chip in.
In my, is there or anyone else?
You can get not only periventricular calcifications, but punctate calcifications also. Many a times, ventriculomegaly mentioned, hydrocephalus there can. And PVL you have mentioned, but apart from these, the neuronal migration disorders are less likely to be picked up on the ultrasound. Even on CT, you will not pick up, as in this case, it is a normal.
Yes. Sir.
What is the investigation of choice ultimately? Ultrasound is at bedside, it has different advantages. So investigation of choice will be MRI of the brain to pick up the neuronal migration disorders. Can you name any one migration disorder? Neuronal migration disorder. Anyone? Have you heard of Lissencephaly, polymicrogyria, microgyria, pachygyria? All these are neuronal migration disorders. They are not going to be picked up on the CT also. So you will have to eventually do an MRI. Yeah.
This is a report of CMV PCR, which was positive. CT, which is normal. On day of life 22 to 36, we started this child on injection ganciclovir, total for 2 weeks. On day of life 37, oral valganciclovir, which is started. Child was clinically pale, so we sent investigation after 14 days of completion of injections.
One moment, Dhaval. Ganciclovir was started on day 22.
Yes, sir.
Why was this delayed?
Sir, actually,
should we have started it earlier?
Yes, we can start, but there was affordability issue was there. Ganciclovir was not governmentally supplied, and torch profile was came later as our institute is running it every 15 to 20 days after that. And then we sent this investigation CMV PCR outside. So parents were arranging for the money and all. So this delay was due to that. Affordability issue.
How early we should start and what are the indications for ganciclovir in CMV infection?
In CMV infection, sir, if it was a severe infection which suggests you of a clinically plus urinary PCR is positive, then we have to start.
Is this baby having a severe CMV infection?
No,
I mean,
actually, sir, only clinically child is having only petechies are only there. So
we do not know. We do not know for sure because blood culture was negative. The baby had sclerema, baby had shock.
yes.
Can there be sepsis-like presentation of CME? In CME,
Yes, sir,
can
it
there
might
be
be.
a sepsis-like presentation?
Yes, it might be possible.
There is one presentation. There are two kinds of presentations. One is predominantly neural manifestation. Another is this acute infection, which may mimic with multi-organ involvement, usually with multi-organ involvement. I mean, in that case, you will have HS megaly, predominantly splenomegaly, petechiae. You will have rashes with a shock maybe sometimes. But in this case, we are not very sure whether it is just CME plus sepsis or it is CME itself which is masquerading as a sepsis.
Yes, it's no.
So will you be starting ganciclovir so early within before baby is stabilized? Will that help, or will you wait first? And how does it help ganciclovir? If at all we start to ganciclovir. Does it, which manifestations does it help? I will ask you another direct question.
Neurodevelopmental, sir, child neurodevelopmental will in future life it will be helpful for neurodevelopment.
It will be useful whenever baby has neural manifestations. So
Neural
that is a
manifestation.
clear-cut indication for giving ganciclovir. Another is the baby is having symptomatic CMV where there is multi-organ involvement. The third indication, and which is most important and most practicable, is sensory neural hearing loss. Even if baby is asymptomatic and we have this SNHL, we are going to start this ganciclovir or valganciclovir. These are the indications for starting antivirals.
Okay, sir.
Hepatitis, chorioretinitis, bone marrow
Yeah,
suppression.
retinitis, ophthalmologic manifestations. Yes, you are very right.
SGPT was slightly higher side, sir.
It was just
71.
borderline high. So
Right, yes, sir.
these are the
Otherwise-
clear indications whether the baby is having severe CMV infection, multi-organ involvement is there. Not sure in this
Yeah.
case. Neither CNS involvement, nor sensory neural is yet to be not ruled out completely.
Yeah.
Liver enzymes are not elevated. Then chorioretinitis are not there. CNS
Is not
infection is not there. So I'm not very sure whether this treatment is justified for this baby or not. Okay, only just single
I agree.
thrombocytopenia.
I agree.
And anemia was, sir, ongoing. Child is actually gaining weight daily, but HB was constantly dropping from initially. So after completing 14 days of injectable, HB was around 7.1. Still, child was gaining weight and on supplemental iron also. Total count again decreased to 3,700. Platelet was normal around 1.9, and at this time, PETs were not there. Routine investigation, SGPT again came back to normal, and RFT was also normal.
Was
So
the
we gave
SGPT raised initially, Dhaval?
71, sir. Before starting this antivirals, we send a routine investigation baseline to compare it the
So
side
was
effect
it,
of
how is your interpretation? 71 SGPT. How do you interpret it? Is it normal?
actually
It's a
borderline
beta,
side. It's
maybe.
almost
What is the cutoff in neonates?
neonates actually. I don't know.
This is what you postgraduates have to, when you are learning, look at what is normative data. You should be having the tables and charts and interpretation. It's not just having a laboratory, multiple laboratory tests which are available in the market, but how to make use of them, how to interpret. That is the key as a clinician. Now this, in neonates, there are no normative cutoffs for SGPT at least, even for alkaline phosphatase. So we take more than 3 times the adult value, which is
Then
usually
it's
40 or 45 according to the lab as a normal. So 45 into 3, that becomes 135, 140. That is the cutoff for SGPT. Then we say it is raised.
So Dr. Nihal says 40 units per liter.
Sir,
Is it okay?
sorry, sir.
sir, are you asking me anything?
No, sir. Dr. Nihal commented in the chat box 40 units per liter something.
Yeah, then it becomes 40 into 3, 120 will be your neonates. For neonates, that will be the cutoff as a neonatologist for me.
Okay, sir.
ROP examination was done on 20th April, around 32 plus 2 weeks of gestation age, suggestive of bilateral, both high immature retina in zone 2 with no plus disease, which was repeated after 1 week with same results. There was no plus disease. Follow-up examination was advised after 3 weeks. Patient was kept in MNCU for the weight gain, and patient was discharged on day of lab 45.
Dhaval, what is the duration of ganciclovir you would recommend?
Ganciclovir, sir, total given for 2 weeks, injectable, and followed by.
Have been given. Total you have given ganciclovir for 14 days. So what should have been the
After 14 days, we sent routine investigation, but we give injectable for 14 days and we discharge this child for on valganciclovir oral.
So what should have been the duration of valganciclovir?
It's 2 to 4 weeks.
It is higher. It
And
can be
Sputnik
from
also
6
added,
weeks to 6 months, depending on the condition of the baby.
Yeah.
We will not be giving it till for 2 weeks only.
Yeah,
It is a very long, the drug is of a very long duration. It has to be monitored strictly. What are the side effects of valganciclovir?
yes.
can cause pancytopenia in this child also.
Hmm.
And hepatitis, pancytopenia, it's mainly seen in this child.
So have you monitored for that?
Yes, sir, but there was no thrombocytopenia, but the HB was falling, so we were confused at that time. It's due to that injectable ganciclovir or that pathology is going on in the baby. So
How
we
many
gave
babies have you seen of 31 weeker having an HB of 7 at around 7.5 months?
hardly 1 to 2%, sir.
Sorry?
Hardly 1 to 2% only.
No, the number is far higher. It depends on your how much lab you are doing. What is already the baby had GI bleeding. You had to keep him NBM for a longer time. The baby had sampling were there. Multiple
Yes.
samples were
Yeah.
being taken. So that is,
Exactly,
bloodletting is one of the commonest cause for anemia.
exactly. That you have to remember the postgraduate. The biggest cause of anemia in neonates admitted in NICU is syringe.
Yes.
The syringe which you are moving around with, removing blood of every now and then. Because this baby had multiple investigations, as Kunal sir has mentioned. So that could be contributing. I have not understood about CBC on 37th day with TC of 3,700. Is it related to the drug? I'm not sure. That could be. Neutropenia is one of the adverse effects of granulocytopenia. So whether that is related to that, but the platelets are okay. Neil, madam, you want to comment something about drug toxicity?
Sir, actually, I am outside and traveling, so there is
No,
lot
no,
of
you can
disturbance over there.
still you can comment on that. No, there is it's free. You should be.
Yes, yes, sir. So I'm audible. Actually, there is lot of noise around me. That's why.
Okay, no issues. Yeah.
Feeding history. MEN at 50 ml per kg per day was started at 12 hour of life. As baby
One
tolerated
moment, Dhaval, I just want to comment on one thing before we go ahead.
Okay, sir.
I have not seen the lower part of the slide. What is that follow-up examination, and then what is it written after that?
Patient kept in MNCU for weight gain and discharge on
Okay.
40 day
Okay,
of life
okay,
45.
okay. What is that MNCU?
Mother newborn care unit. It's
I
like a
understand that, but what is your concept of MNCU?
mother neonatal.
Where the mother is also in care
Yes,
unit,
mother and
isn't
baby
it?
kept together.
Not only neonate. Many a
Sorry,
times
sir?
mothers are stable, we shift the baby to the mother, that doesn't become MNC. Mother and baby have to be together. We give kangaroo care in a designated facility or somewhere where the babies are stable. Here the mother and the baby from the 0 hour, zero separation policy or IKMC, immediate KMC, as you might have heard about, is zero separation policy. Mother and the baby are admitted in the same unit. Mother is taken care by obstetricians, the baby is taken care by the neonatologist. So even if the baby requires intensive care, ventilation and all those things, it will be by the side of the mother. And mother is also requires care, baby will be taken care of. So this MNC concept is not like mother and baby are together. It can be kangaroo care also. We keep so many babies for weight gain with the mother. It doesn't become MNC. Is it clear?
Yes, sir.
So the best way is the family-centered care. The family-centered care provides the baby along with whole of the family, and the mother
Yeah.
is the essential part. When
Exactly.
wherever the baby is kept along with mother, even with the ventilation going on, even with all the therapies are going on, the baby is there with the family and the mother with them, and that is the best way. But even in India, we have some restrictions on the structure and the space management. That's why the concept of MNCU chipping. So in MNCU, we have the mother, and on the mother's chest, there is a baby. So mother takes most of the care of the baby. 80% of the care is taken by the mother, and only 20% the baby requires is the doctor.
Okay. Okay, ma'am. Feeding history. Initially, we started MEN at 12 hours of life, and babies tolerated well. So we gradually increased by 10 to 15 ml per kg per day. On 72 hours of life, RT feeding was stopped in view of RT aspiration and abdominal distension. On the 7th day of life, as there was no brownish aspiration, so we restarted RT feeding, and which was gradually increased to the full. Supplementation and fortification was started on day of life 10 as the baby reaches to the 80% of total RT feeding. Gradually shifted to the spoon feeding, and BF trial was given, and patient was discharged on full breastfeeding followed by Pilates feeding as the child was preterm and gaining weight well. This was a picture of baby when SF trial was given. Summary.
Dhaval, one
Uh,
question, one short question.
yes.
What is the upper limit to increase your feeds? You had given by 10 to 15 ml per kg. So is that the upper limit or not?
For
What
increasing RT feed, sir.
Yes.
Sir, some literature says we can start with 100 ml per kg per day from day one also.
No, that I'm asking you, what is the till how much you can increase? Suppose you are giving 5 ml today, tomorrow will you be giving 6, 7, 8 or any, or you will be slowly gradually increasing the feeds, or will you rapidly increase the feed?
Gradually increase the feed.
Can you
20 ml per kg per day, sir.
So it can go up to IS 30 to 35 ml per kg also. If you are giving an pure express breast milk, so that helps in reducing the better weight gain of the baby also. So you need not restrict your feed increase up to 15 ml per kg. You can increase faster also. Okay.
Okay, sir.
So Dhaval, the range is 20 to 40 ml per kg. That we also follow it in the whenever there is MEC and we are increasing the MEN. So you can see if the child is tolerating better. It's not always that you increase by 20 ml per kg. You can even increase by 40 ml per kg. So that is how you can shift and rapidly increase the volume.
Summary. Early preterm 31 weeks 5 days. Very low birth weight 1.3 kg, appropriate for gestational age. Male baby now day of life 45 with the corrected gestational age of 36 weeks 5 days. Was admitted in to NICU in view of RDS and preterm care with a generalized pedegia. Baby was given 1 dose of surfactant, phototherapy, and 1 unit of PEG cell volume. Diagnosed as a congenital CM infection, and a total 14 days of injectable ganciclovir. It's actually 6 mg per kg per dose. I wrongly mentioned here. Were given followed by the oral valganciclovir on discharge.
Dhaval, one moment. You mentioned double surface phototherapy.
Yes, sir.
So what is the purpose of giving double surface phototherapy in this baby?
Sir, bilirubin, serum bilirubin was in phototherapy range, so we started double
What
surface.
chart did you follow? How much was the bilirubin? which day of life and gestational age, and what chart did you follow, or any criteria you followed, or your unit follows, any policy?
Yes, sir. There are chart to look for the as baby is falling in high risk, normal and low risk babies. So according to that only, I actually name of that chart I don't know.
Did you
Sir,
follow the
uh,
chart, or conventionally
Yes, sir.
you
We
are
follow the
following that
yes.
formula of birth weight into 5 or something like that?
No, sir. We follow the charts only.
If you are following, then you should look at it very carefully, isn't it?
Yes, sir.
And secondly, what is the flux, irradiance for an intensive phototherapy? The purpose of giving double surface is give intensive phototherapy. In preterms, you have to be very careful in giving intensive phototherapy. But if you are using for the purpose of double surface phototherapy to increase irradiance, isn't it?
Yes, sir. As child was, sir, preterm.
What is intensive phototherapy, I am asking? And how do you measure irradiance at the bedside with the phototherapy? Have you heard of irradiance?
Yes, sir.
What is
sir,
the
your
unit of
unit have
irradiance?
yes. Your unit have irradiance meter or not?
Have
It is
that
also called
transmitter,
as
na?
flux
We keep
meter.
that and
Flux
then-
meter रहता है. So if it
Yes,
is
sir.
more than 30, then it is called intensive phototherapy. Then nowadays DSPT is very rarely needed. We have most of the LEDs, blue LEDs, and they give consistently about 30.
30 years.
Only thing
Usually
you
we
have to
said
ensure that the baby's surface is adequately exposed. The phototherapy is not tangential, it is perpendicular. All those precautions. Yeah.
Yeah, Dhaval, you had not mentioned the bilirubin levels in your case
yes, sir.
presentation.
It's mentioned later on in chart.
So later on it is mentioned. And does it carry any importance?
Yes, sir.
What?
If a child is as child is preterm and if child is having a torch infection also, so and child is on antiviral, so it might be affecting the treatment of the child. So it's important. Yes.
So one thing is one of the commonest presentation of CMV can be direct jaundice if it is not being diagnosed at the time of birth. This baby
Yeah.
had petechial rashes with preterm baby was there admitted, so you had diagnosed and thought of a torch infection. But some of the babies who present with direct jaundice can be their first initial symptom for visit of an NICU. Okay, so it is not always that petechial rashes are there. So whether this baby you are mentioning, so it is one of the important finding which should have been mentioned in your case presentation itself. So this was the bilirubin level of the baby. Okay, and is there any significance of giving PCV? Any correlation between CMV and PCV?
Yes, sir. Generally, CMV infection childs having normocytic normochromic anemia. Anemia is only.
Anemia can be one of the presentation, but is there any association between CMV and your blood? So
How is the CMA transmitted? Is it one of the routes? Blood transfusion.
Yes, blood. I was thinking blood transfusion to the baby. Yeah, so
How is it transmitted through blood? What are the cells the CME is carried into? RBCs, leukocytes, or platelets?
it affects the leukocytes, sir.
So how do you try to prevent in newborn or immunocompromised? Suppose they can be adults also. You
We
answered
can
partly.
use the leukocyte filter. So
Yeah,
we can
leukocyte
prevent it.
filter, leukocyte depleted, irradiated. Sometimes if that facility is available.
Yes, sir.
in
So
a
we may
premature, yes. So if a premature baby is there, if you had given him a blood transfusion and later on you find out that the baby is having a persistent anemia, the baby is having a direct jaundice, then you should investigate the baby for an CMV infection.
Okay, sir. Okay.
Okay. And that can be the one of the cause for, because blood is never being tested for CMV. So as sir had told, leukoreduction along with irradiation should be the ideal type of blood which you should be giving to the baby to prevent CMV infection.
Okay,
And
sir.
one moment, Dhaval. What are the indications of PRBC transfusion in preterm babies? PCV transfusions.
As it increased
I
the
mean,
oxygen.
it is just a practical guideline I'm asking.
If a child is on ventilator or any support, then we consider as a HB around 13 to transfuse PCV. And if O2 requirement is there, then we consider as a 11 cutoff, 10 to 11, and then we transfuse for the
In
PCV.
this case, it was 7.1.
Yes, but the child was constantly gaining
But
weight.
that is for stable preterms. We have to use, we can use at 7. Okay. Yeah.
Okay.
Yes.
So diagnosis, preterm 31 weeks, 5 days, normal vaginal delivery, very low birth weight 1.3 kg, appropriate for gestational age, with HMD, with NEC grade 1, with anemia of prematurity, with probable sepsis, with shock, with neonatal hyperbilirubinemia, and with congenital CMV infections. This is the investigation chart. Initially HB was around at time of birth 16.7. Second, within 24 hours, it around 17.6. Then it dropped to 14.2, then 12.8. Then at last it was 7.1. So then we transfused the one PCV. Initially platelet count was 1.3, which decreased on third day to 55,000, and we consider as a sepsis, and we started antibiotics and all. And at time of starting oral antivirals, platelet was around 1.9. And the CRP, first CRP was 0.6, then it increased to up to 5.6, and then it becomes the negative after completion of 14 days of antibiotic. And other reports were almost normal range.
So this chart should have been at the beginning before your
Beginning.
diagnosis.
Okay, sir, I will keep in mind.
And that too, your direct, you have not mentioned anywhere your direct bilirubin.
Yes, sir.
Okay.
Okay, sir.
Yeah.
On examination, baby is in radiant warmer in supine position with a partially flexed posture in sleeping state. Vitals temperature was, child was euthermic. Warmer temperature was showing the 36.8 degrees centigrade. Heart rate was 142 per minute, showing in chest leads. Pulse well palpable in all 4 limbs. Respiratory rate was 44 per minute. Saturation was 98% on room air. Capillary refilling time was less than 3 seconds. Blood pressure was 58 by 38 in right upper limb. There is no any signs of pallor, icterus, edema or cyanosis. In anthropometry,
this examination is done at what time?
At time of sir, before 3 to 4 days of discharge, around 43 to 44 day of life.
Okay.
Anthropometry, at birth, child's weight was 1.3 kg, which falls between the 10 to 50th centile. Length was 42 centimeter, around 50th centile. Head circumference was 28 centimeter, between 10 to 50th centile. And on discharge, around 37 week of gestation, corrected gestational age. Weight was around 1.54 kg, which falls less than third centile. Length was 46, between 10 to 15 centile, and head circumference was 30 on third centile. This is a graphical presentation of Fenton's chart for the same values.
So what is
On
this
head to
called?
toe
Dhaval, what is this called?
chart, sir.
Yeah, this chart is a Fenton's chart.
Yes, sir.
This type of growth, what is it called? like you have intrauterine growth retardation. So the major problem after birth is extrauterine growth retardation. Child is going into extrauterine growth retardation. So there can be multiple causes because of sepsis. If baby was unable to feed, you had not given him TPN. So this all can be the causes of extrauterine. So this again is a bad indicator for the neurodevelopmental outcome growth of the baby. Okay, so even when you recognize at this point, this baby will need a proper follow-up. You should take care of the growth of the baby, even the head circumference is being falling. Okay.
On head-to-toe examination, head anterior frontally as level, size 0.8 by 0.8 centimeter, posterior frontally just hip. There is no any swellings in head. Face, there is no any
One
dysmorphic
moment,
feature.
Dhaval.
Yes, sir. Yes, sir.
Number one, anterior fontanella, you measured dimensions. I'm not asking you how did you measure, how do you interpret that 0.8 into 0.8? What does it convey to you? Is it normal? And what is normal? How did you conclude that? What is normal size of the in a 32-weeker going out to become 37?
37, yes, sir. It's a
Yeah.
normal in size, sir, actually. Child
What
is
chart did you
37,
follow,
which
or what is the normality? How do you decide? I mean, is it just because you are presenting that is why you are so measuring and doing that? Or do you do it routinely? And how do you interpret and what is its significance? And which babies you should be measuring? I mean, normal practice, I don't think we are measuring, to be very honest.
sir, as
My
a
unit
routine,
also, we
I
are not
actually
measuring
measure
the
this.
anterior quaternally, isn't it?
Yes,
It
sir.
is good
If
that you
it's
measure,
open or
but you have to know that anything you record or measure, know how to interpret it. Otherwise, don't measure it. If you are
okay, sir,
not using it for clinical purpose or not able to interpret, don't measure it.
okay, sir.
For exam presentation is a different art. Taking history is a different art. So you have to learn these arts. The difficult things you should leave. Don't just mention. So that is not a common practice. There are charts for your information. There are charts of anterior continental size. If you know the Smith's book of human malformations, recognizable patterns of human malformation by Smith, that will give you all sorts of chart, philtrum length and all that, evaluation of a dysmorphic baby. So you sit with the chart only and the tape. Okay. Yeah.
As there is no signs of any cataract, subconjunctival hemorrhage, icterus, or any discharge. Nose pressure sore are present over the nasal bridge due to that O2 was child was kept on nasal prongs and all. Ear
Could
recalls
have
was
been
normal
baby was on mask or nasal prongs.
on nasal prong at last. Sir.
Why is it
After-
on the nasal bridge? It has to be on the septum.
What's it? I didn't get you.
The pressure sore is over the nasal bridge. So where does the usually pressure sore is there?
At the septum.
Yes.
Initially,
Not at
child was
the
on yes, child was on CPAP only. So oral cavity, though no any natal teeth, tongue, no any symmetry or deviation. In neck, there is no any mass or swelling. Chest normal in shape, no retractions are there. Abdomen, there is no any distension. Umbilical cord fallen off. Abdominal girth was 22 centimeters. Back, no any tuft of hair is there. In genitals, male phenotypes, both testes in scrotum. Extremities in upper limb, no any deformity. Bilateral brachial and radial pulses are well felt. In lower limb, bilateral femoral pulses are well felt. No evidence of DDH or club foot. In symmetric systemic examination, I first examined respiratory system. Respiratory rate was 44 per minute. Abdominothoracic type of breathing. There is a no retraction at present. Breathing movement bilaterally symmetrical. Air entry bilaterally equal in all areas. Clear. No any foreign sounds were heard. In CVS, heart rate was 142 per minute. Apical impulse visible in fourth intercostal phase, mid clavicular line. S1 and S2 is normal. There is no any heart murmur. Per abdomen on inspection, temperature was normal. No abdominal distension or visible bowel lobes are there. Umbilicus in centrally placed. No umbilical hernia. No cord fallen. Umbilical cord is fallen off, and there is no any discharge on palpation. Abdomen was soft. There is no any hepatosplenomegaly. On auscultation, bowel sounds were no.
One moment, Dhaval.
Yes.
You are mentioning about umbilical cord has fallen up 2-3 times.
Yes.
So anything
Yes,
in
sir.
your mind why you are mentioning that?
As a part
You
of
expect this
inspection, I
baby
mentioned it, sir.
when you are examining after say 4-5 weeks, no umbilical stump will be there, no?
Yes, sir. After 7 days,
Are you
generally falls.
expecting this baby to have a delayed cord fall? And what are the causes? What is delayed fall of umbilical cord? When do you see?
12 days of
It's usually 2 weeks. 2 weeks
Yes,
is the cutoff, we say. Beyond that, if it is still not fallen off, then what are the reasons? Common reasons I am asking, not rare reasons. In day-to-day practice, also sometimes we come across such type of babies. It is usually if the cord is kept wet, dry cord care is the norm. If that is not done, then maybe that is one reason. But in those cases, it is likely that the cord will be infected. The most common cause is an umbilical infection. The stump will be led to fall off.
infect.
That is why we teach about neutropenia, granulocytopenia, or chemotaxis defects. It is another cause of delayed cord fall.
Yes.
Yeah.
On CNS examination, higher mental function, child is sleeping, but arousable. Cranial examination was normal. On motor function, posture, all four limbs are partially extended. Tone is normal in all four limbs, and power is 3/5 on all four limbs. Neuronal reflex is routine sucking, Moro's reflex, grasp reflex, lateral tape were present. So my final diagnosis is child is early preterm, 31 weeks, 5 days, normal vaginal delivery, male child, very low birth weight, 1.3 kg, appropriate for gestational age with HMD, with NEC, with probable sepsis, with stroke, with anemia of prematurity, with neonatal hyperbilirubinemia, and with congenital CMV infection, and with preterm care.
Yeah, leukocyte. Yes. How will you follow this baby? Now, this baby
First
has
is
already
advised for
congenital
after
CME infection is there, isn't it?
Yes.
Will
As a child,
you do some additional evaluations in this baby?
we advised for
You-
MRI, but relatives were not affording for that.
MRI is
So
one thing. What else?
yes, we advise for a routine blood investigation after 1 month, as child is on antiviral, to look for the toxicity of the drugs, to
Okay.
look for the pancytopenia and hepatitis or something is developing or not.
Okay.
As
So
there are
you
chances
will
of sensory
monitor the
neural
drug toxicity. You will do an MRI for complete evaluation of the brain.
yes,
You will keep him in developmental follow-up.
yes, sir.
Will you repeat a hearing assessment?
Yes, sir. As there are chances of sensory neural hearing loss is more common with CMV infection. So ENT follow-up is there for Bera and
Okay. So what do we expect in this baby? Vis-a-vis congenital CME, what are the predictors of poor outcome? I mean, is this baby a candidate for some sequelae of CME? or this is just a transient infection and baby has come out of it?
For the second PCR we didn't send, so we don't know the status of that viral copies and all. But as child is not falling in a severe CMV infection, so it's likely to have any neurological deficit in future life. And ophthalmology and ENT examination were also within normal range at time of discharge.
Most importantly, we are not yet sure as to what is happening to the brain. And
Yes, sir.
head growth is lagging.
Yes, sir.
It is little concerning, isn't it?
Yes.
But it could be various factors like Kunal sir has mentioned about extra-uterine growth restriction that will be contributing to head growth lag, or it could be underlying some brain problem, which is why the CME infection may not have been picked up. So we have to evaluate, do an MRI. Then only we can say that the baby's CNS is normal. And we need to keep a close follow-up for hearing assessment. Maybe repeating it, it can come up anytime, not necessarily at birth only. So we need to do a hearing assessment, and then
Yes.
the usual neurodevelopmental or high risk follow-up of these babies.
Yes, sir. Every monthly we have to follow this child for weight gain, neurodevelopmental, and for this toxicity and all.
What immunizations will you advise at the time of discharge for this baby? This baby
So
was
routine,
probably, hopefully, as I understand, it is not immunized yet, isn't it? At the time
no,
of
sir.
discharge, baby was not immunized.
No, at time of discharge,
So-
child was not immunized. At
So what
first
immunizations? What immunizations will you advise? It is Prajapati sir's topic, but I am just asking.
sir, birth vaccination are advised at OPV, hepatitis B and BCG, as child's at time of discharge only. Birth vaccination.
OPV, what OPV is it? It is I don't understand.
Oral polio vaccine at
It's a
birth.
zero dose. You mean?
Hepatitis B, yes, 0.
I don't know about that. Are there any recent changes of using zero OPV? This has to be at birth only, no longer it carries any significance at this age, 5 weeks. Sir, you can correct me if I don't understand. Because we are not dealing with immunizations at all. Feeds people, they look after that.
Child was not reached to around 1.8 kg, so we advise vaccination at follow-up.
What other vaccinations he will give? Will you give rotavirus to this baby? And how early?
At once a child reached to the weight 1.8 kg, then we can advise this child. As a child reached
Usually, when is the first dose of rotavirus is given? If you are
usually
using
it's
it, it
given
is
at
not in national. Yeah,
6 weeks of age.
yeah, 6 weeks. He is almost there, no, at the time of discharge.
But sir, corrected gestational age was around 37 weeks only. So, and weight is also 1.3 kg.
Will you be waiting for this baby to become 6 weeks chronological age?
Yes, sir.
I mean, not chronological age.
Corrected.
Corrected age.
Correct.
Yeah.
Yes, sir. We will wait for that.
But I think that is not the case. Sir, yes. I was waiting for you to come in.
No. Dhaval, can you stop sharing? I think you have
Yes, sir,
completed
we
the presentation.
Yes, sir. Yes.
First, I am extremely sorry that I could not join due to this laptop issue. But I attended the case from the very beginning. And let me appreciate Dr. Dhaval. You have done a very good job.
Yeah.
Thank you, sir.
You have very
Yes,
good
very
answer.
good.
Yeah, very good
Yeah.
presentation. And both the neonatologists have done I will say, fantastic job for the students, Dr. Deshmukh and Dr. Kodal.
Thank you, sir. Yeah.
And the thing story was going on. I joined later on. Then I thought that I should not disturb. It is going on very well. So I thought that it is very good learning for all of us and should be continued. The only thing I think other students on the screen should join in the discussion,
Yeah.
so that it becomes, I would say, live
Lively
discussion,
discussion.
and it's a good interactive session.
Yeah.
Here, on the contrary, I will appreciate that alone Dhaval, but he could fight very nicely. We know that it's very difficult job, even at our age, and we understand that at the resident it's most difficult. But still,
Yeah.
I will appreciate you. Definitely, you have done the very good job.
Yes, sir.
Some of
Without doubt.
some of the points which I have noted, I thought that in between I will not disturb because I joined late. But I thought I will put at the end of the session, and I think now we have about 15 to 20 minutes. Though I think the discussion was going on very nicely regarding the neonatal screening.
Yes,
There
sir.
are so many points, but distinctly in the ID chapter, what we discuss for the neonatal screen, there are the three important points for the neonatal screening. Number one, absolute neutrophil count and its morphology. Band cells or these multinuclear cells are very important. Second, we go for the IT ratio. That is more important. And third is the CRP. And they say that even suppose two of these three are positive, you may consider probable sepsis in the absence of positive culture. And you can start the antibiotic accordingly. So I think very clearly we should have the answer for the interest screening. But at the same time,
Yes, sir.
I think now I'm sure that these neonatologists will agree with me that now the early sepsis, neural sepsis, the differences probably have almost gone. Because looking at these organisms and even the source hardly makes difference. The point is, actually any neural sepsis, once, we suspect, then we have some positive points on screen, therefore we say probable. And third, if you get the culture positive, we say confirm. And accordingly, we should start. But here, what happens, that suppose if you're not gone for the CSF, if you're considered probable or suspected sepsis, maybe recovers. And therefore, you will stop the antibiotics after 7 to 10 days or 2 weeks time. And that what happens, if you have not done the lumbar puncture, by chance, if it is meningitis, which is possible, which will be missed and will present to you as a complicated or even the sequelae with this partial treated bacterial meningitis. That may be in the form of the ventriculitis or even the hydrocephalus or even the brain abscess. And then you know that it becomes very difficult because number one, permanent damage to the brain of the baby. And even in the court of law, it becomes very difficult. So once probably if you go for these antibiotics, I think lumbar puncture should be essential component to rule it out. Since I will say very important message, which we should keep in mind. Second, which I noted, you started with the change of antibiotics, meropenem and colistin together. What was your idea? Which organism you are targeting to treat? I hope that gram
Sir,
negative.
as blood culture was showing negative and child was clinically deteriorating, so we started as a broad spectrum.
Yeah, but what I mean to
gram
say,
negative.
broad spectrum. Which organisms are going to be covered by meropenem and colistin?
Staph and gram negative and all. We can cover that.
Which one? Sorry.
Staph aureus and gram negative organism.
Which one? Which antibiotic will cover the staph among these two, meropenem and colistin?
Staph will be covered by meropenem, sir.
Is it? Is it? No. That's why purposefully I asked the question. There is no anti-staph in this regime
MRS
at
will
all.
be, yes, sir. MRS will be covered by polystyrene and Baki
No,
other
no,
organism.
no. MRSA will not, even any staph will not be covered by this meropenem and colistin. And therefore, purposefully, probably this is seen in the practice also. That's why I wanted to make it clear. Meropenem and colistin, both even, will be covering only the gram-negative organisms.
Negative.
But once you find the problem, nowadays even the imipenem, that is meropenem, resistant organism also. And really, if you have got it, you will go for the colistin. Very rarely, even where partially even the meropenem effective and colistin, then meropenem colistin together. Otherwise, either the meropenem or colistin. I think together don't get any extra benefit. On the contrary, toxicity of these antibiotics. Suppose if you have got even culture positive, gram-negative organism, which is resistant to the meropenem, which is seen even in, I will say nowadays in our busy or the congested nurseries, then you have to go for colistin. But I think together, no purpose is served. So that's very important that which organisms are targeted. Suppose if you don't have the culture positive, then clinically, epidemiologically, or even the organisms common in your nursery, you will consider. But with that, I think choice should be there. Second, something, I think you were discussing anterior frontal 0.8 centimeter.
Yes, sir.
Sir was, I think Dr. Deshmukh was discussing very important point. What does it indicate? I'm sure that 0.8 millimeter is 0.8 centimeter is that is 8 millimeter. Definitely very small in size. And what does it indicate?
Suggesting premature closure.
Yeah, and what is the likely cause? Very important.
Underdevelopment of brain.
Because there
Child
is
is
no, they are likely here. Suppose if you are following this patient and anterior is going for early closure, that means there is a baby is resulting in microcephaly.
microcephaly.
There is no stimulus for the brain to grow for the anterior. Therefore, and suppose by chance, even very important question Dr. Deshmukh was discussing on follow-up, if you see that AF is on the contrary disproportionately larger, increasing in size, what will you suspect? Suppose initial
Hydrocephalus or dilated ventricles.
yeah, hydrocephalus, absolutely. And therefore, serial measurement of head circumference and examination of AF is very important clinically. Besides, of course, is sonography and other radio imaging, which you can go. I think umbilical cord, fallen off rather than what you should know on examination, umbilical cord absent.
Yes.
That's all.
Absent.
That's all. Present or absent. Or otherwise,
Okay.
where it has fallen off, that you should note it. If the mother or somebody has noted.
Noted.
And very, very important point was discussed, delayed fall of this umbilical cord, usually 2 weeks, but by definition 3 weeks.
Okay, sir.
Most of the situation, 7 days is the time, 7 to 10 days. Most of the babies, they will lose the umbilical cord. Some babies may take even the 2 weeks. But to define the delayed fall, it should be by 3 weeks. And very important causes too, besides the sepsis or if you have kept the cord, even the weight, but otherwise pathology or conditions point of view, leukocyte adhesion defect, and third is even the factor 13 deficiency. Factor 13 deficiency is known, which I think somebody may ask in their exam also. I think some point of discussion for doing and not doing the CSF blood culture, how it is related to blood culture in the CSF. If I understood properly, that because probably your point was that CSF was not done because blood culture was sterile. Was it right? like
No, sir.
that?
Actually, sepsis we consider was early onset within 24 to at 20 hours of life we started antibiotics. So
Anyway, the point is, I think irrespective of it, CSF examination is very important because you know that there will be no sign, may not be any symptom, but still meningitis and particularly in the preterm babies, very likely. And
yes.
preterm babies are more prone to develop the problems and complications, ventriculitis and hydrocephalus and abscesses and so many issues which we should keep in mind. I think USG skull was discussing very important, particularly in the CMV, you will get that the periventricular this calcification is the characteristic because they have the, I will say, affinity for the periventricular cells. In a case of toxoplasmosis, the calcification will be scattered in the skull. But while this from the differentiation of the even the pattern of the calcification also you can think whether the toxoplasmosis and cytomegalo. And cytomegalo, I think here it was diagnosed very rightly that how it is to be done. Very important that PCR in the urine is very important. So many points of management already have been discussed. So I think I may not go for repetition of it, but at the same time, at the end, your presentation was definitely very good. Discussion was going on so nicely. I will say by both the experts. I'm extremely sorry that I joined late, but I will request even other students who join in the screen rather than to remain on the chat box and keep your video on. Anyone, you should interact very lively. You always, even whatever you speak may not be right. Even you can ask the question. What is your perception, your interpretation? You should express. Do the on the contrary more mistakes. If you do the more mistakes, you will learn more. Just due to the fear of mistake, if you don't speak, if you don't participate, that is a great loss. So I think by learning for learning, I think Nihal, yes, now he's keeping his video on. I was watching his, I will say, comments, but I think that, always interactive session will be more interesting, more learning for everybody, for student, for the teachers, and that becomes the more, I would say, effective. So I request you from the next time, maximum students should be on the screen. I would say whoever is presenter should bring his own friends. And the friends should be, I will say, competent to discuss. And even they should say that you are wrong. Always the first reaction should be that you are wrong. By that, on the contrary, that competition should be there. And by that, you'll be able to learn more. But certainly, I will say that is the best way. Again, over to you, Dr. Nihal. And extremely sorry due to this, my technical problem of the laptop. I was quite late. I think next time I will even manage it also in time so that technical issue should not create the problem. Thank you very much, Dr. Deshmukh. Really, I was learning not many points you were discussing very nicely. And even Dr. Kunal. Thank you very much again.
Thank you for those
Dr.
words
Nihal
of wisdom from you, sir.
Thank you.
Yeah.
Over to you, Dr. Nihal.
Thank you so much. Thank you so much, Deshmukh sir, for running the whole show. Even though
my
it
pleasure.
was, so I
For
think
me,
it is
it
difficult
was
for
an
him.
experience. I told you that I am not taking any MD pediatrics exam since 10 years. I left pediatrics 10 years back.
Yes,
I'm
sir.
just
So
into
I think it was
neonatology.
difficult for you to take a MD pediatrics exam again than taking the neonatology one.
But it was a good experience and I like the way the interactions happened.
No, but I
Thank
will
you so
say,
much, sir.
I will say every teacher should be able to do first MBBS, then MD, and I think then DM. But the basic, every teacher will have to continue. That is very, very important. Here I am able to see Dipti after a long time. Really, very nice to see you, Dr. Dipti.
I was in
So-
pediatrics, sir, for your information. I was a professor of pediatrics for 7-8 years.
Yeah, I know you very well.
Before I became professor of neonatology.
Yes, sir.
Yes, sir. So thank you so much, Deshmukh sir. Thank you so much, Kunal bhai, and giving the so much inputs during the case. though our center is not as equipped for the point of care center as having your center with all the USG available and all the point of care for the newborn is available. But still, Dhaval tried his best to present the
Yes,
case.
presentation was very good.
Yes, presentation
must-
was good, and thank you, ma'am,
Thank
for
you,
the
thank you so much.
opportunity. Yogesh
Yeah.
sir, Baldev sir, for the opportunity. It was a learning experience for me too. Also.
Thank you so much.
Thank you.
Thank you so much, Baldev sir. Your presence always glorify the event.
No,
So the points to ponder is there at the end with whole of the એટલે એમ કહેવાય ને કે નિચોડ આપી દીધો ગુજરાતીમાં એમ કહીએ આપણે. So it was very nice interaction and the points at the last. Dhaval, you must have learned many things with the
Yes,
case,
ma'am.
and I must appreciate your preparation. And also Dipti, uh, thank you so much for preparing and encouraging your student for presentation in the e-class. And
you, ma'am.
I thank you everyone, those who are present, especially Nihal, who has given so many comments. So now onwards, Nihal, you can even interact during the this case discussion, and also encourage your other friends to come and chip in with the discussion.
Yes, ma'am.
Yep.
Thank you, ma'am.
Thank you so much all. Thank you, Clarinet,
you.
for giving this
Thank
platform.
you, ma'am.
Thank you. Bye-bye.
Madam,
Thank
Thank
you.
Doctors.
let me congratulate Dhaval for the
Thank you,
excellent presentation, because in the last 2 days we have finalized the case on the neonatology, and Dhaval prepared it within 2 days, and the excellent presentation as all appreciated. Carry on, Dhaval, and keep it up. Thank you.
sir.
Thank you,
All the
Deshmukh sir,
best.
and
Yes.
Baldev Prajapati sir, Dipti
All the
madam.
best.
Yeah.
All the
All
best.
Thank you, madam. Thank you, sir. Thank you, sir.
Yeah.
Thank you.
Thank
Thank
you,
you all
ma'am.
Thank
doctors
you.
for
Good night.
sharing such valuable insights. And I would also like to thank for extending us the opportunity to host you in this session. And I look forward to hosting you again. Till then, everyone stay safe and healthy and have a nice day to all. Thank you.
Yeah.
Thank
you.
you. Good night.
night.
Good night all.
Good night.
Good night.